Good afternoon again. Next 30 minutes, I will be talking about the ultrasound-guided injection of shoulder pain. And I have no disclosure of financial interest about this presentation. Use many applications and platforms for this presentation and books and reference. You can see in the slides. And this presentation, I prepare prepositioning and anatomic illustration and some ultrasound image of commonly scanned shoulder structures. And you can see in the slide the commonly shoulder structures which we have performed interventional procedures on shoulder joint. And let's start with bicipital tendon. This muscle is more commonly known as a biceps and is located on each arm between the shoulder and the elbow. The biceps brachia has two heads, a long head and a short head. You can see the long head here. And this is a real cadaveric picture. You can see the transverse ligament and the long head of the biceps, and a supraspinatus muscle and tendon, and a subscapularis tendon as well. When you put your transducer over the anterior window of the shoulder like this, the transducer beams cut the tissue like a knife. So you can see the most superficial muscle is deltoid muscle, which is under the skin. And you can see the clearly greater tuberosity, lesser tuberosity, and long head of the biceps as well. This is the sonogram of the anterior shoulder. You can see clearly the long head of the biceps sonogram, and the perfect shape and transposed to the anatomic structure. It's an easy way to learn to ultrasound-guided everything, ultrasound-guided interventional procedures as well. This is a reverse anatomy practice. I usually use this method for the education. And you can see the transducer and the patient position in this slide, and you can see the same sonogram. This sonogram shows the bicipital tendonitis. You can see the hypoechogenic fluid around the biceps tendon. You may notice that the irregularity of the tendon and abnormal echogenicity. The bicipital tendon sheath is connected with the glenohumeral joint. If you see the peritendinous effusion, but bicipital tendon shape and echogenicity as normal, this fluid may come from the glenohumeral joint. You have to think this. In my daily practice, I usually prefer an in-plane approach with the medial to lateral orientation for peritendinous bicipital tendon injection to prevent puncture of the anterior circumflex humeral artery. This is the short axis in-plane approach. You can see the transducer position and the patient position. When you turn your transducer 90 degrees, you can see the bicipital tendon in a long axis view. The sonogram shows the fluid and synovial thickening surrounding the bicipital tendon sheath. You can do this procedure with long axis view and in-plane approach like this. You can see in the slide transducer position and the patient position. This is a long axis in-plane approach of the bicipital tendon peritendinous injection. Let's look at the acromioclavicular joint. The acromioclavicular joint is the articulation between the clavicula and the scapula. Since there are no muscle that act directly on this joint, the movements with it are entirely passive. When you put your transducer over the AC joint, the ultrasound beams cut through the tissue like a knife, like this. Sometimes we need to tilt transducer a little bit, the best view of the AC joint sonogram. And you can see this sonogram. This is the AC joint. You can see the acromion and a clavicula and the acromioclavicular ligament. The AC joint injections can be performed with an in-plane approach like this. Or you can perform the procedure of AC joint injection out of plane approach. While performing an out-of-plane approach, you can see only the tip of the needle. You can't see all the needle. So it's very important for the beginner. If you are a beginner of the musculoskeletal ultrasonography, a spatial interventional procedure, I advise you can choose the in-plane approach for the visualizing all of the body and the tip of the needle. The bursae are fluid-filled sacs that roll over themselves and lubricate the possible friction points between the muscle and the joint capsule. The major bursae in the shoulder include a subacromial bursa, subdeltoid bursa, and coracobrachial bursa. You can see this bursa here. This is a subacromial bursa, subdeltoid bursa, and the coracobrachial bursa, and there is a subcutaneous acromial bursa as well. When you put the transducer at the lateral shoulder window, the sonogram demonstrates the subacromial subdeltoid bursa. And normal condition, the bursa is essentially seen as a potential space. You can see in the sonogram subacromial bursa and subdeltoid bursa as well. When you tilt your transducer for the best view, and you keep in your mind the subacromial bursa is sandwiched between the rotator cuff muscle and the out layer of large bulky muscle. It can commonly become inflated and cause the pain, and you can inject into the bursa ozone, local anesthetic agent, steroid, or something else to help to decrease the pain and elevate the pain and the anti-inflammatory effect. You can inject long axis in plane approach into the subacromial subdeltoid bursa with ultrasonographic guidance. Like this. And when you turn transducer 90 degrees and inject something into the bursa in short axis, anterior to posterior in plane approach. I prefer anterior to posterior approach and in plane, like this. When let's look at the glenohumeral joint. When you excluding the superficial anatomic structures, the glenohumeral joint would appear. The glenohumeral joint, also known as a shoulder joint, articulates between the humerus and the scapula. It's ball and socket type of synovial joint in which head of the humerus represent the ball and the glenate fossa of the scapula as the socket. I will show the intra-articular injection of the glenohumeral joint. This is the posterior window of the shoulder joint. It's suitable for the intra-articular injection to glenohumeral joint. Put your transducer at the posterior window of the shoulder joint, like this. This is the sonogram of the glenohumeral joint at the posterior side of the shoulder. You can perform your procedure in plane axis, in plane approach, but you have to pay attention. You shouldn't puncture the glenoid labrum because you don't want to puncture any healthy anatomic structures such as labrum or arteries and veins. When you put the transducer over the anterior window of the shoulder, like this, the ultrasound beams are cut the tissue. In this sonogram, you can see the subscapularis tendon. This is a long axis view of the tendon. A fibrillar pattern is seen along the tendon, which insert into the lesser tuberosity. And when you turn your transducer 90 degrees, you can see the short axis view of the subscapularis tendon. This is the short axis view of the subscapularis tendon. And you can see hyperechogenic fibers and the hyperechogenic fibers and the hypoechoic cleave due to interposed muscle fiber among the tendon fiber. And you can perform a peritendinous injection, short axis in plane approach, like this. In this short axis image, you can see the central hyperechogenic subscapularis tendon defect. This is an intrasubstance tear of the subscapularis tendon. And you can see the partial tear of the subscapularis tendon. This is a partial tear of the subscapularis tendon. And the long axis view of the subscapularis tendon, there's a sonogram, and you can see the full thickness tear of the subscapularis tendon. And the long axis view of the subscapularis tendon ultrasound image show to us over the anterior aspect of the shoulder, and we can see the subscapularis tendon calcification. This is the transducer in the patient position for evaluation of the supraspinatus tendon on a long axis view. This sonogram show a long axis view of the supraspinatus tendon. You can see the articular cartilage. This is a good shape and a perfect shape of the articular cartilage. And you can see the deltoid muscle and the subacromial subdeltoid bursa as well. You may notice that the arrow indicate the anisotropic artifacts of the sonogram. This is a long axis view, and you'll prefer in plane approach for the suprascapularis tendon injection, like this. When you turn your transducer, you can see the short axis view of the supraspinatus tendon, and you can see the subacromial subdeltoid bursa as well. And the bicipital tendon is the right side of the sonogram. And this is a perfect shape of the cartilage. And you can perform your procedure in plane approach. This sonogram demonstrates a short axis view of the partial thickness tear of the supraspinatus tendon and the long axis view of the full thickness supraspinatus tear. This is a partial tear, and this is a full thickness tear of the supraspinatus tendon. And when you would like to examine the infraspinatus tendon or inject into the, or peritendinous injection to the infraspinatus tendon, you can see in this photo the patient and the transducer position for evaluation the infraspinatus tendon as a long axis view. You can see the sonogram in a mere tendinous junction, infraspinatus tendon, and Grestert bursae. You can perform your procedure in plane approach as well. Maybe you can choose the out of plane, but in my daily practice, I usually use this approach. This is a longitudinal image of the tendon, shows a diffuse thickening and hypoechogenic seen the infraspinatus tendon, and you can see the multiple hypoechogenic area with loss of fibrillarity structures are presented infraspinatus tendinosis. And another sonogram shows several supraspinatus tendinitis and tendinosis and intrasubstance tear. You can see the diffuse thickening of the tendon like this, and you can see the intrasubstance tear of the infraspinatus tendon. Another important structure when we're talking about the shoulder joint, the suprascapular nerve. The suprascapular nerve is the lateral branch of the spirit trunk of the brachial plexus. It received the nerve's fiber originate in the roots C5, C6, sometimes C4. This is a mixed nerve, meaning that it provides both sensory and the motor supply of the suprascapular region. In addition, the suprascapular nerve provides sensory supply for the joints of the scapula. And this sonogram this is a sonogram of the suprascapular fossa. You can see the transverse scapular ligament in the sonogram and trapezius and the supraspinatus muscle. This article is about the suprascapular pulse radiofrequency ablation for shoulder pain. And we look closer to the suprascapular fossa. This is a supraspinatus fossa as well. Another name is. You can see the artery, vein, and the nerve of the. Okay, this is a great picture, and this is a great sonogram of the suprascapular fossa. In my daily practice, I usually use this approach, the medial to lateral side in plane approach for the diagnostic suprascapular nerve block or radiofrequency ablation of the suprascapular nerve. It's not exactly ablation, but because we don't want to ablate this nerve due to motor function. I prefer the pulse radiofrequency. It's not just it's not a real ablation. It's just neuromodulation for the long term of the shoulder joint pain relief. And you can see the sphenoglenoid notch here as well, but I usually prefer my procedure at the suprascapular fossa. And there is one more thing which is important. Dr. Felice Galusio and the colleagues are describe a novel block of the shoulder, and you can find this article by scanning this QR code, and the paper published in Pain Physician. You know that the suprascapular nerve is responsible to 70%, and the axillary nerve is the 30% of the innervation of the shoulder joint. And you can see in the slide why we need a novel shoulder block. Please read this article carefully and scan this QR barcode and find the article. You can find all the sonogram and all the process of the steps of the study. And this photo from study, which is performed on fresh cadaver, you can see the interfacial space to axillary nerve, and you can see the other target of this shoulder block, pericapsular space on fresh cadaver picture. And you can find in this article what did the Dr. Felice and colleagues are find, what's the indication of this shoulder pain. And Dr. Felice educate to us and show to us how can we perform this procedure step by step. The first step is localizing the humeral head and the coracoid process with arm slightly internal rotation. As you can see in the sonogram, we'll see the coracoids and the humeral head, but we can not see clearly the scapularis tendon. Then the external rotation of the shoulder, we can see the subscapularis tendon and the myotendinous junction clearly. Then the next step to localize the perfectly our target is put the patient with arm external rotation and abduction, and you can see the clearly in the skin the coracoid process, the humeral head, and the subscapularis tendon and the myotendinous junction. And now we can localize our target. The first target is the interfacial space between the lamina of the deltoid muscle and the superficial of the subscapular muscle. This interfacial space. And the second target, as you can see here, there's the Timblake line is the pericapsular space between the myotendinous junction and the joint capsule. The first injection here, and the second here. If you would like to perform this shoulder block with a suprascapular nerve block, change your position, get behind the patient and turn the transducer to the first position, and you can start your injection with the first interfacial space to reach the axillary nerve, and going down, and you can reach the pericapsular space to reach all the terminal articular branch. And I would like to thank you, the special thank you to my colleague for describing this novel blog. And thank you so much for your attention.